Welcome to Grand Rounds. Please remember to sign the attendance record at the back of the auditorium, and then also please remember to turn in the audience response systems and also the program evaluations, and if you could give us any ideas in regards to future topics and future speakers, we are always appreciative. Today, it's my pleasure to actually reintroduce Dr. Dan Fulton. Dr. Fulton attended to his undergraduate education here at Iowa State, then went to the University of Minnesota for medical school, did his internal medicine residency at Hennepin County, and then his infectious disease fellowship at the University of Iowa. And then, thankfully, for those of us who are routinely faced with complicated and challenging infectious disease problems, he decided to come back to Ames. He has accepted our invitation today to update us on with an interesting title. The title of his talk today is Fantastic Beasts and Where to Find Them. And please join me in welcoming Dr. Dan Fulton.
Well, I'd like to thank you again for having me today. It's a pleasure to be here. I wanted to give this talk because I think being here in Ames, you know, in a smaller town, it's easy to forget or not appreciate that even here in semi-rural Iowa, we can encounter some pretty fantastical things. And so, as I was trying to come up with a title for this, the notion that gets talked about a lot in infectious diseases is big beasts, you know, severe infections. But that wasn't quite the feel we were going for. So I thought fantastic beasts seemed like maybe more appropriate name. And so we're going to be doing a case-based review. So we'll have 8 cases to talk about today. These are all cases that were seen and diagnosed here. In Ames and Mary Greeley. I don't have any particular disclosures to tell you, and you know, I hope to give you a general sense of the approach that we take with maybe more unique presentations or rare diseases. You'll see there is sort of a pattern to our thinking, and I hope to review some of the common pathophysiology with you of some of these rare illnesses, and then also some clinical pearls in the management of some of these diseases. So just for introduction, this is our infectious diseases team. Oh, sorry, it's not them. Here's our infectious diseases team. So you can see Dr. Arbulu is the hero and our fearless leader. And then Nasreen and Kristen are our nurses who really make things happen. And then Kelly is our administrative person who really holds us together. But really the ID team extends beyond just our office. We see patients when they're referred to us, and so they've always been seen by somebody else first. And so our team really extends out to all sorts of other doctors, specialists, primary care doctors, and then also public health nurses, and also the lab is a huge part of what we do, so thank you guys for everything. So infectious disease is really fun because it's truly a team effort all the time. So let's jump into case number 1. We do have 8. I'm going to try and move quickly through these. So I wanted to have this as case 1 because this, in fact, was my very first case here at Mary Greeley. So I had finished my orientation, and Dr. Arbulu very kindly said, well, why don't you take the next consult? And this was that consult, very first one. So this was a 17-year-old. She came in with fever. It had been going on for about 4 days, mostly at night, some sweats and fatigue. She felt kind of crummy with some myalgias, headache, and specifically right behind her eyes. She didn't have any neck stiffness, cough, or other symptoms, no medical history. She looked kind of sick, but really not toxic, a little tachycardic, but otherwise her exam was pretty benign. Let's see. So I want to do a brief aside. When we think about fever, because this gal has a fever, the differential is really broad for fever. So when we think about fevers, we always think about fever plus something. Somebody never has just a fever. They have to have fever plus something else. So that can either be like a symptom, like a headache, which might suggest meningitis. It could be fever plus maybe a specific exposure, like maybe you deliver sheep and we're worrying about Q fever. It might be fever plus a season or an epidemiology, like your nursing home has an influenza outbreak. It might be fever plus a specific lab, like, you know, hepatitis. Or maybe it's a day and it's Saturday night fever and has nothing to do with an infection at all. Fever, it turns out, is actually explained chemically. So the hypothalamus is a deep part of the brain that has the temperature set point, and that part of the brain is in constant interaction with a number of chemical signals. And so these might be caused by infection or injury or inflammation, and those chemical signals down at the bottom there, such as IL-1, TNF-alpha, or IL-6, all cause various cascades once they get into the brain. You can see that one of the things that they stimulate is prostaglandins once they get through the blood-brain barrier, and that's how Tylenol works, is it inhibits prostaglandins. It turns out that multiple studies have shown that treating fever or not treating fever doesn't really affect outcomes of patients. So even in the ICU, randomized trials of people getting Tylenol or not getting Tylenol, there was no change in outcome. And probably that's because fever is actually helping us fight infections. So any harm it might do by causing tachycardia or hypotension, it's actually helping get rid of whatever the underlying problem is. It does this by stimulating neurons. So you can think about the hypothalamus like a metronome. It's sending a constant signal out to the body to help control temperature. And if it gets a chemical signal that it needs to increase the temperature, then the metronome increases. Those nerve signals go out, and they cause shivering of the muscles and vasoconstriction to help draw heat in and drive fever. So back to case one. In her case, she's not giving us a lot of extra information. She's 17. She's got some body aches. So your initial impression might be this sounds like mononucleosis syndrome, like EBV. So that brings us to really important point number 2. And if you've heard me talk before, this is a thing we'll always talk about. I learned this during my training at Hennepin County from Ron Scott, an ID doctor there. And he always says, know your oats. So we'll talk about our oats for every case. Oats are your occupation or the patient's occupation, any animal or activities that the patient does uniquely, any travel, and any sexual activity or shooting up. So if you know these things about your patient, you're going to know a lot about what they might be at risk for. So in terms of her oats, she was a student at Iowa State. Oh, and let me say, a lot of these are unique cases, so I did change a number of the details just to help de-identify anybody. So she's studying at Iowa State. She does have a goldfish at home, and she does clean the fish tank, which I know makes you think of Mycobacterium marinum, but that was a red herring in this case. She is from a place called East Java, which is in Indonesia and Southeast Asia, and she had taken a trip there over the summer and didn't take any prophylaxis because she's from there. And you'll find that's pretty common in people that travel home, is they don't feel like they need preventative medicine because it's where they're from, but that puts them at higher risk because their immunity might have waned over time. She's not sexually active and she doesn't use IV drugs. So this is really fever in a returning traveler, which is a specific subset of fever. So I think you might have audience response things. Did you guys get those? So if you knew nothing else about her, this is a fever in a returning traveler, what would be your number one differential in fever in a returning traveler? Very good. Okay, so I think we'll close responses at 73. So let's see. So in terms of responses, many of you picked malaria, some of you picked dengue, some of you picked typhoid, and a few influenzas. Very good. So in terms of her labs, white blood cell count was low, platelets were low, and she had a little bit of liver inflammation, normal kidneys, normal chest x-ray, and she did get an immediate malaria antigen. Many of you answered that question correctly. Fever in a returning traveler, less than 7 days. The differential is malaria, malaria, and malaria, and then a few other things. So you should always be thinking malaria in these cases first, and we'll talk a little later about the malaria antigen. She was HIV negative, which we check in really anybody that comes in, And ultimately, her dengue antibody came back positive. So welcome to Mary Greeley Medical Center. Your first case is dengue. So this is fantastic beast number 1. This is a flavivirus. You may have heard of other flaviviruses like West Nile, Zika, or yellow fever. Dengue has actually 4 different strains, and it has a huge disease burden worldwide, almost 400 million cases per year. Most people do pretty well with this infection and don't actually get that sick. There's a difference between dengue fever and dengue hemorrhagic fever. If a person gets dengue hemorrhagic fever, the mortality in a rural area can become very high. So here at Mary Greeley, how are you going to find dengue virus? So in terms of epidemiology, these folks almost all have to have been overseas. There has been a few case reports from southern Texas, and we anticipate with climate change that dengue will move north over time. We're not sure how far north it'll get, but it could get to Iowa. This is the distribution of dengue virus worldwide, and you can see it's very much a tropical illness. These mosquitoes feed during the day, unlike malaria mosquitoes, which feed at night. It's classically called breakbone fever, so people will describe a horrible fever with usually a retroorbital headache and body pain that is just overwhelming. Labs are exactly what she had: low white count, low platelets, and some liver inflammation. And the way to get this diagnosis is to think of it and you can send a protein which will find dengue within the first week, or you can send an antibody which might be negative early on because the body hasn't had time to make antibodies yet. My experience with the NS1 protein is that we send it to Mayo Clinic and we actually get it back the next day, so it can be very helpful in what might be an early case. Treatment is mostly supportive, but you need to be aware of what's called the critical phase. So these patients can get something called capillary leak syndrome. So right as their fever is starting to break, all of a sudden it's like all their blood vessels just start to leak, and they will develop rapid hypotensive shock and pulmonary edema. And it's kind of disconcerting because it's right when you thought they were getting better. So most of these patients in developed world should be hospitalized to assure this doesn't happen. The WHO has a number of recommendations if you're in a rural area about who can be hospitalized and who can stay at home. I'd say here, if you're worried about dengue, they should just come in. Steroids and IVIG are probably not that effective. It's mostly just giving them fluids and treating any transfusions related things that they need. One interesting thing about dengue is that these 4 strains actually predispose you to getting sicker each time. So if you get dengue virus number 1, you might get just a fever, but then if you get dengue virus number 2 after you've had number 1, that's when you get dengue hemorrhagic fever and you get much sicker. So people that live in a dengue area are more likely to get severe disease because they get re-exposed. That's made vaccine development really challenging, because how do you give somebody a vaccine, have them have a response, but then they get dengue and they get super sick? So there is one vaccine that's approved. It's only approved for people that live in endemic areas, and you can't get it until you're 9 years old because they want you to have already been exposed to most of the strains before you get a vaccine that helps kind of boost future immunity. So in summary, fever, bad headache, blood findings, low white count, low platelets, liver inflammation. You know, you never know the answer right away. So we were worried about typhoid, for those of you that picked typhoid. We gave her some azithromycin while we were waiting for these studies to come back, but once dengue came back positive, we could stop that. She did not develop capillary leak, and she recovered without any post-dengue fatigue syndrome, which happens in about 30% of people. They just can't function. I've had a patient lose her job over just not being able to work after dengue. Okay. Case 2. So this is a 20-year-old man who comes in with 7 days of fever. He's got some headache, feels bad, some abdominal pain. We found a rash when we saw him. He didn't know he had it. And the course of his illness is sort of interesting. He got high fevers for about 2 days. And then he started to feel a little bit better. But then over the last 3 days before he came in, he got much worse. And this headache became just horrible. So he had just returned from a missions trip to Haiti maybe about 3 weeks before, and he was doing some volunteer work there. He has no past medical history, doesn't take meds. He looks sick, although his vitals are normal. And the initial question on him, he was in the ED, and the question was, well, if this is anything, maybe it's dengue, maybe we should just send him home and kind of do close follow-up. But the first thing I noticed when I went into his room was this. So these were not his eyes. This is somebody who has the same illness's eyes. But you can see there's something not quite right there. His labs show that he's got thrombocytopenia, low platelets, and some liver inflammation. So in his case, let's see, you have, you can see Haiti there in relation to Iowa. It's in the Caribbean. So you need to know your oats. So you get one question before he gets too lethargic from the Dilaudid that you get to ask him that might inform the direction you take this case. So feel free to answer. Did any mosquitoes bite you? Did any ticks bite you? Have you been camping in Colorado or the Carolinas between when you got back and now? Have you eaten any undercooked meat? Did you go swimming in any waterfalls? Or did you have a new sexual partner while you were in Haiti? HIV rate is not insignificant in Haiti. So we're at about 60. Okay, so we're going to go ahead and move forward. And so the majority of you wanted to know about swimming in waterfalls, some about undercooked meat, and some about mosquitoes. I wonder, Dr. Arbulu, could you comment, what did you want to know about this patient, and how are you thinking about this case? That was normal so far, fortunately. So I kid you not, this is exactly what he said. It's funny you should ask, but on our second to the last day, we did in fact go to a waterfall, and we jumped and we swam under it, and there had been a lot of rain, and so the water was really brown. So Dr. Arbulu, could you tell us what the diagnosis is? So the diagnosis is Leptospira, and that is fantastic beast number 2. So this is an interesting organism. It's actually a group of organisms. There's 21 of them that we know of. They infect humans and animals, and they don't grow in usual cultures. They do occasionally grow, but you have to get some very specific media, which is hard to find. The rodent is probably the main reservoir for this infection, and so we're always asking about any sort of rodent exposure. And in fact, that the picture of that kid's eyes that I did show you, his story was that he was in Thailand and he was helping his mom in the rice paddies catch rats. And so he had a good risk factor. So how are we going to find Leptospira here at Mary Greeley? So these are mostly tropical illnesses, but you can see them here in the States. Almost always there's some rodent or freshwater exposure. For boards type exams, this is always somebody that's been whitewater rafting in Costa Rica. I don't know why, but that's what the boards will ask you. And it often occurs after in an outbreak form with flooding. So as sort of weather events get more severe with more flooding, we anticipate there to be more Leptospira infections over time. Fever is abrupt, people have headaches, and about 40% actually have aseptic meningitis, and I bet he would have had that if we would have tapped him. What's interesting is there's sort of a biphasic illness. The organism gets in, it starts to grow, your immune system does what it can to try and fight back, but then basically your immune response causes a lot of the liver and kidney problems that you get. This is one that's tough because you really have to think of it, and the antibodies don't develop until about 2 weeks later. So you can't be fooled by an initial negative test because until 2 weeks from now, it'll be negative, but if you wait until then, your patient will be dead. So you start doxycycline, which is the mainstay of treatment. And one thing to be aware of with this type of infection is there's something called a Jarisch-Herxheimer reaction, similar to syphilis, where Patient might look pretty fine, and then you start the treatment, and basically all these little bacteria are really sensitive to antibiotics, and they all explode, and all the toxin inside of them just immediately gets released into the body, and people can really crump on you. And that's what he did to us. So he developed a really high fever of 103 about 2 hours after the doxycycline. So I was glad we didn't send him home because he got hypotensive shock, and he ended up in the unit and needed a whole bunch of fluids. But after about 48 hours, he seemed like he turned the corner. And so this is just, this shows you that those antibody levels are usually initially negative when somebody's first sick. And this talks a little bit more about the immune phenomena, which we'll skip. So in his case, fever, headache, rash, a biphasic illness, low platelets, and liver inflammation with water exposure. So we tested for malaria and dengue in him also because we didn't know at first. His initial leptospira antibody was negative, so we didn't stop. We kept going, and then we repeated that 2 weeks later, and he did convert to positive. So the hemorrhages in him and the biphasic illness were real clues. And then when he says, "It's funny you should ask, I did spend time in a waterfall," that was really the giveaway. So he's completely recovered, and he hopes to go back to Haiti this year. Case 3. So this is a 24-year-old man who comes in with fever, headache, and fatigue. He went in 48 hours ago and was told that he had mono and was given some acetaminophen. He really doesn't have any other symptoms, no past medical history. He looks sick, and interesting about him is he could not get up. I mean, we brought him in, and he was laying in the waiting room across a couple of chairs, and we got him in the room, and he immediately needed to lay down on the table. So that's called prostration, and he was prostrate. He could not sit up. He was very febrile, and he had some mild scleral icterus. And so we need to know our oats. So he's a graduate student, no animal exposure, but he recently, within 7 days, returned from Ivory Coast, which you can see right there, in West Africa. So he's married, monogamous, no IV drug use. So, if this looks like the same question, it's because it is. So, differential diagnosis. Pick your most likely thing, most likely cause of fever in a returning traveler. Very good. So, excellent. So, a lot of malaria. I know that the rest of you picked chikungunya just because you want to hear me say it. So, this is not chikungunya, fortunately. So his labs showed low white blood cell count, low platelets, some bilirubin elevation, and a clear chest x-ray. And so this is when my old professor, Dr. Williams, would have said it's time to go big game hunting. And so the first thing we do is we look at a peripheral smear. And if you're squinting at that and you want to see it a little better, here you go. So I took this with my phone through the eyepiece in the lab. And so you can see here the classic finding of earmuffs. So there's only one thing in the world that looks like earmuffs inside of a red blood cell, and that is Plasmodium falciparum. So he has acute malaria. Now I admit I got to cheat a little bit because he had a positive malaria antigen, and when he got referred over to us, we actually had him go to the lab first, and we had that blood sent right away. So before we even saw him, we had his antigen test. So this is how the antigen test works. It's a card, and you put a little serum on it, and basically there's a control, and then if the T2 is positive, that's specific for falciparum, and that matters because people get more sick with falciparum. If the T1 is positive, that suggests a different species of malaria. If they're both positive, that might be a co-infection or probably just falciparum that is really reactive. So this can be really helpful because some of these parasite levels can be pretty low and you might miss it on a smear. A negative test is not perfect, but it's pretty good. I think we've had one false negative here in the last couple years. So this was a case of malaria, Plasmodium falciparum. For any future board exam takers, this is the banana shape that you might see on a peripheral smear as well. Plasmodium falciparum is the only malaria species that will do that. So if you ever see that, they give you that picture, it's always falciparum. There are 5 species. Falciparum is the one that makes people most sick, but there's these other 4 as well. and this causes hundreds of millions of cases a year. But over the past 15 years, there are fewer cases due to mosquito control programs, and the mortality rate is down because health systems are improving in areas where this infection is worst. This is the current location you can find malaria, so the red and the orange. Interestingly, before we had good, tiling and drainage in Iowa, there was malaria in Iowa 100 years ago. Fortunately, not anymore. They do anticipate that malaria may spread somewhat with climate change, but not as much as some of the viral illnesses. So if you were looking for it, really somebody needs to have traveled overseas. If you didn't take prophylaxis, that's a risk factor. But if you did take prophylaxis, you still might get malaria. And these mosquitoes feed mostly at night. People come in with fever and some high bilirubin. And if it's falciparum, they feel sick. I think every case we've had, the patients always just want to lie down. They just can't get up. We always want to know if it's severe or not severe, so we're looking for end organ damage. If they're confused, if they have kidney problems, if they have pulmonary edema, that might be a sign they need IV treatment. And then we look at this smear also, and we count up what % of the cells have malaria in it. And if it's over 4% or so, we worry about severe disease and they need IV treatment. That's important because the best IV treatment is artesunate, which you can only get from the CDC, and they store it in Chicago. So this would get flown into us if we ever needed it. We would give the patient quinidine and doxy until it came. But most of our cases are not severe. They're kind of mild to moderate. So in his case, and I think in most of our cases, we give atovaquone proguanil, and you basically take 4 pills a day for 3 days, and that's it. So chloroquine resistance, chloroquine used to be our treatment of choice. Really now, around here, it's really if somebody got their malaria in the Caribbean, you can use chloroquine. Even then, the Malarone, the atovaquone proguanil works really well, so we kind of lean on that mostly. For him, fever, couldn't get up, some jaundice, low platelets, and then his malaria antigen came back almost immediately. So it makes finding this a little bit easier if you think to test for it. The treatment is fairly straightforward if it's not severe. And then he really thinks he probably had malaria before, which is one of the reasons he didn't get so sick. So people from endemic areas have a natural immunity that keeps them from getting sick. But if he spends the next 10 years in Iowa and then he goes home again and he doesn't take prophylaxis, he could get really sick. And that's actually when we see people get most sick, is when they're visiting friends and relatives, because they don't feel like they need prevention. So we always, part of the treatment in him is to say, you need prevention when you go home, because this doesn't have to happen. And think about the rapid antigen, because that really helps the whole process go. We do that here at Mary Greeley. So case 4, this is a great case. 68-year-old guy who had a fever and low platelets, and symptoms came in about 3 weeks ago. He had some tiredness, and just these fevers kept going, and he just slowly got worse. And so this was a subacute onset. This has been happening for several weeks. He'd had some labs that showed the low platelets, but he just wasn't turning around, getting worse. And now he's getting some headaches, and so he got referred over from Western Iowa. He had malaria as a child, which you don't usually hear in people. No really interesting meds, and he looks sick, but he's upright, a little bit of a temp, but he doesn't have meningitis on exam. And so know your oats. So this is a great boards question, right? So he was born in Iowa, but he grew up in South Africa with a missionary family, but now he lives in Western Iowa. But over the last 2 months, he went to Tanzania and South Africa. He didn't take prophylaxis, and he was feeling fine when he got home. So he went back to work as a hunting guide, where he goes to Iowa and Minnesota and spends time in Missouri and Colorado, and he'll take people out, and they'll be camping and stuff. And right now it's about the fall season, and he did notice some sort of bite on his right knee when he was up in Minnesota. Asked if he has animal exposure. He says, well, sure, they've got deer and rabbits and pheasants and turkeys, and he does trap raccoon too. He is married, monogamous, and does not use IV drugs. So there's his rabbits and his coons, and there is South Africa and Tanzania. So you have a few things to pick from. Initial labs showed mildly low white count, low platelets, and mildly elevated LFTs. Chest x-rays clear. So, differential diagnosis, what's your number one for this guy? Could this be malaria? Could it be a more mild form of malaria? Could it be anaplasma, a tick-borne infection? Could it be Ehrlichia, a different tick-borne infection? Could it be relapsing fever? That's a tick infection from Africa. Could it be Babesia, or could it be Francisella? Okay, so we'll go forward. Oh, whoops, no, I lost it. So I think most of you said Francisella, which I liked, because that should be a reflexive rabbit exposure. If somebody is sick with fever and has a rabbit exposure, very good. You should always think about Francisella, because people can get really sick from that. And then people are thinking about tick-borne illnesses as well, which I like. He had a really quick malaria antigen negative, and then we had requested a bunch of other studies, including a peripheral smear. And I'm glad Dr. Weidert is here, because I reviewed this with him in the path lab. And what you can see here are these little things in the red blood cells. So it's not really a ring like you'd see with malaria. It's kind of this oblong looking thing. This one's maybe more ringy looking. That's a little bit more round looking. So if this guy had not been to Africa a month ago, we would have had the diagnosis, because there's only one kind of red blood cell parasite in the Midwest. So, but he had been to Africa, so we wondered maybe this is just weird looking, and so we sent antibody levels, and his Babesia level was through the roof. So zooming in, you can sort of see this kind of oblong looking thing in the red blood cell right there. So fantastic beast number 4 is Babesia. So this is also a protozoan like malaria. This is transmitted through tick bites, occasionally through blood transfusions, because they don't screen for this. And the reservoir is the white-footed mouse, just like Lyme disease. So the tick basically feeds on the mouse. Then the tick has to survive the winter, where these little parasites mate in the tick's gut, and then they migrate to the tick's salivary glands, and then it bites you the next year, and then that's how it gets in. So this is almost always a summer or fall illness. It's not very common in Iowa. It's much more common in Minnesota and Wisconsin. There was one case reported in 2016, and that was ours in Iowa, and I actually think he probably got it in Minnesota with that bite on his knee. People come in with fevers, sweats. It's usually more subacute. That kind of comes on slowly over time. People will get really sick, though, if they've had a splenectomy. They can just come in looking septic. But the real clue here is that peripheral smear showing some sort of RBC parasite, and most people have not also been to Africa recently. You can get serologies like we did, but again, those can always be negative early on, and they take some time to run. So in his case, he had been started on doxycycline because people were starting to think it's summer, what about a tick-borne illness? And what's important about this organism is it's the one tick-borne illness infection in the Midwest that does not respond to doxy. So if you have somebody that has a tick-type illness and you give them doxy and they're not getting better, you should be thinking about this. If they're really sick with a high parasitemia, you can think about an exchange transfusion to take the bad red blood cells out and put the good ones back in. In the classic boards question, they'll show you this Maltese cross in a red blood cell, and that nothing else does that. So that's that is Babesia. So in him, fevers again, low white cell count, low platelets, transaminitis, and then a parasite in his red blood cells. He got treated with the tovacone and azithro, and he completely recovered, and he's probably camping somewhere right now. They can relapse if they're immunocompromised, so we did get follow-up labs in him about 2 weeks later just to make sure that his smear was negative and he didn't have any hemolytic anemia, and he did not. And so I wanted to pull this up in part because I put all 4 of these first cases together, and you can see that they look a lot alike. So fevers, low white count, low platelets, inflamed liver. And so we actually see that pretty commonly, especially in the summertime here in Iowa. usually it's not one of these fantastical infections from Africa. It's more likely to be something called Ehrlichia or Anaplasma, which we see here. And you will not uncommonly hear us say, in a case like this, we'll just start doxycycline. We have a low threshold to give doxy in the summer in Iowa. And the reason is, like all of these illnesses, it takes a couple weeks for the antibodies to turn positive. And if you wait around to get positive results, you may miss your opportunity to treat somebody. So, low threshold for doxycycline in Iowa if you have this pattern: fever, low white count, low platelets, hepatitis. And then we do the testing, and if they're not responding, then we start to wonder about Babesia as well. Lest you think that all of these cases have previously been to Africa, they haven't. So case 5 has no travel. Well, not really. So this is a 60-year-old guy who comes in August. He's been having headache for 4 days. It's kind of come and gone, but then he started to get confused. So he has some neck stiffness. He had some rash and some oral ulcers a few days ago. Past medical history didn't tell us too much. And so clinically, he had meningitis. He had stiff neck, headache, fever. So he had mildly low platelets, mild transaminitis, and his head CT was normal. His CSF did show meningitis. So he had 41 white blood cells. They were mostly PMNs. The protein was normal, the glucose was normal, and he had a negative gram stain. So he had what's called Meningitis Panel, and this panel looks for all of these different potential infections, and you can see his were all negative. We started using this panel about 2 years ago, and it's super helpful because this runs in about an hour. You can get all this information back. We've run almost 200 panels in the last 2 years. What's interesting is more than half of our panels were run when there was no meningitis. So what happens is a person comes in with fever and a headache, they get their spinal tap, and the ordering provider reasonably just says, well, I think this is meningitis, let's order all these tests. Well, a lot of people with fever and a headache just have a virus and it's not meningitis. So we looked at all of the cases that had no inflammation in the spinal fluid, but did have a meningitis panel run, and we never did find any pathogens on any of those. So right now we're in the process of working with our stewardship team to build a behind-the-scenes reflexive thing, so it won't affect what you order at all, but we'll just automatically cancel this panel if there is no inflammation in the spinal fluid. In his case, there was none, or there was some, sorry, so he had the 41 cells, but his panel was negative, so now we're left like, well, what is this? So he's got meningoencephalitis, he's confused, he's got inflamed meninges with some neutrophils and a negative smear and PCR. So we ought to know our oats. So he works in an office. He likes spending time outdoors. They live near Ames, and they have a creek in their backyard. I don't know if you know anybody like that, but pretty common. They have a couple dogs, and he did go to the Czech Republic to visit some family a few months ago, and he was also in Vermont about 2 months ago. He's married, monogamous, and does not use IV drugs. So what's the differential on this one? What are you worried about? So is this a bacterial meningitis that you know, the panel and the gram stain just missed? Could this be a false negative HSV PCR, and he actually has HSV meningitis? Remember, he had some mouth sores. Could this be Lyme meningitis? He's got a creek in his backyard. Could this be West Nile virus, creek in the backyard? Could it be leptospira? He has a dog, although we already did a lepto case. That's less likely. Or could it be a different tick-borne illness like Ehrlichia or Anaplasma? Very good. So I think we'll move forward. So I like that. So Lyme and West Nile are sort of tied, and then another tick illness is also in the mix. You know, the false negative HSV PCR is a thing. So that test is very good to find HSV. It can be falsely negative in the very acute setting. So if your patient has only had a headache for, say, a few hours and your pretest probability is really high for HSV, you might want to repeat that test. But in general, the PCR is pretty good. But we were worried about all those things too. So we had him on ceftriaxone, waiting for bacterial cultures, and that would also treat for Lyme. And we put him on acyclovir for HSV, wanting to see how he would do. And then we sent off some studies. And what ended up coming back was that his West Nile IgM was positive. And IgM antibodies, you know, they're pentavalent, so you can get some false positives, but this seemed to make sense. But either way, we repeated it 2 weeks later, and he converted to a really convincing positive now with IgG and IgM positive. So, fantastic beast number 5 is West Nile virus. We do see this here in Story County and at Mary Greeley. It's a flavivirus, just like dengue and Zika and yellow fever. It's actually originally discovered in Uganda, because the Nile goes all the way down to Uganda. And it really was not in North America until 1999. So somehow it traveled across the Atlantic. There was a huge outbreak in New York, and then over the past 15, 16 years, it sort of spread out, and now it's across all of the United States. So these are the cases that are reported. So you can see in Iowa we have a few. Mostly in western Iowa, and then a lot more in Minnesota, where I'm from, because there's a lot of mosquitoes up there. But you can see August is really the high time for this infection, and that's right when he had it. And they've done seroprevalence of mosquito surveys here in Story County, and we do have this here in Story County. So I think that's where he got it. So you'd be looking for somebody in the summertime who's spent some reasonable amount of time outside. It'll kind of look like dengue with fever and low white count and low platelets. The really dangerous thing is people like him that get neuroinvasive disease. So a lot of people in the summertime that get a transient fever might have had West Nile and they may never know it. In fact, if we go test everybody, a lot of people have been infected and just didn't realize they were. But in him, since he was getting confused, the moment you're kind of confused with meningitis, the mortality rate is about 10%. And I've had 2 patients die from this infection. People can also get this kind of weird presentation of a flaccid paralysis. This can be generalized or radicular in just a specific area. Usually they have some fever with it, and about 33% seem to recover fully, 33% partially recover, and 33% just don't recover from that. So it can be pretty devastating. The way to make the diagnosis is to test antibodies. You can test for DNA by PCR also. And the treatment is really supportive. There's not a lot we can do about this. You can try IVIG if they're have low antibody levels, but even that, it's sort of not great. The good news is that we do think we'll be getting a vaccine for this within the next couple of years. So it may be something that we're able to shut down over time. So West Nile virus is here in Story County. So think of meningoencephalitis and West Nile virus if it's in the summertime. We stopped his antibiotics, and he fortunately completely recovered, and we asked him to wear more bug spray in his backyard. The meningitis PCR gives lots of information, but remember, it does not check for West Nile or Lyme disease. And so if your patient does have a lymphocytic CSF, you should be thinking about those two if your panel is negative, because it won't look for those, and you have to ask for them specifically. And be aware that viral meningitis early can have some mild PMN predominance rather than lymphocyte predominance. So you can't say, well, it's bacterial because it's all PMNs. It may be a virus. And people that come in with encephalitis, it's really unsatisfying for them and for us because most of the time we don't find anything. It's probably just some virus that we don't have a great test for, and then we all just cross our fingers that it'll recover. In big universities where they study this thing, even when they do every test we know how to do, we only find something about 20% of the time, which is kind of scary. So, case 6. We're going to move through these last 3 pretty quick. So this is a 59-year-old guy who comes in with 3 weeks of cough. He saw his PCP, had some nodular changes, and so he was given an antibiotic, but he got a bad rash, and so then he got prednisone instead. He kept having fever and cough. It got a little better with the prednisone, but as it was tapered off, he got worse again. And then he got started on Augmentin instead. So his past history is interesting. He has rheumatoid arthritis, and he was started on a TNF-alpha inhibitor just a few months ago. And has had a great response. You know, his RA is totally controlled. His exam, he looked tired. He was a little short of breath, coughing. He had some crackles, and he had a little hepatomegaly. So we know our oats, so he worked works in an office. He's been doing a lot of yard work and raking leaves lately. This was in the late fall. No pets, but he has noticed there's a lot of bird droppings on his deck. So there's some birds roosting in his trees. He doesn't travel. He's married, monogamous, doesn't use drugs. So his labs are pretty normal. White count's normal, platelets normal, but he had this elevated liver testing, which was a little bit worrisome, and then his CRP was really high at 14. This is his chest x-ray, and I hope you can appreciate here that not only does he have this kind of bigger nodular thing here, but he's got all these little micro nodules throughout. And so the very good news about him is that because he has RA, he felt like things weren't going well, and he just wanted to come talk to his rheumatologist. And I'm glad Dr. Gerbrocht is here. And his rheumatologist immediately recognized that something was not right about just giving this guy more antibiotics. And so what do you think we were worried about? So does he have acute disseminated histo, and we should give him some itraconazole and have him follow up closely? Does he have disseminated histo, and we need to really get him in now and get him started with amphotericin? Could he have TB? And he needs to be admitted, isolated, and started on these drugs? Or is this an atypical pneumonia, and usual beta-lactams won't work, and he needs some azithromycin? Good. So we're going to move on. So good. So this is acute disseminated histoplasmosis. And the clue is that he was on a TNF-alpha inhibitor, and he had negative quantiferon screening, which we really require now for anybody going on a TNF inhibitor. Unfortunately, TNF inhibitors do put people at risk for histo. And his abnormal LFTs were a signal that this fungus was actually not just in his lungs, but in his liver too. And I've had several patients die from, we just didn't get to this soon enough. So he was admitted, got amphotericin. We could measure a huge amount of fungus protein in his blood. And even though he looked pretty good when we saw him, within hours of coming in, he got this really high fever. And he's a pretty sick guy. So Fantastic Beast number 6, this actually isn't that rare. This is histoplasmosis. This lives in the soil here in Iowa. It's associated with bird and bat droppings, but any sort of decaying organic material. What happens is, I think of it sort of like dandelions. The wind comes and kind of blows the spores into the air, and then we all probably breathe it in from time to time, but our immune system just takes care of it. If it does get a toehold, it can cause a cavity, it can cause a pneumonia, or it can then spread into the body like him. So there's actually 250,000 cases per year in the U.S. This is where this infection lives, so we're on kind of a moderate area here in Iowa, and more to the southeast. We see a lot of cases coming out of Missouri after travel. You've probably heard the adage that TB can do anything in terms of your differential. Well, remember that histo can do anything TB can do. So when we're thinking about odd infections or things in weird places, lymph nodes that are swollen, masses in the pancreas that are granulomatous, we worry about histo here in Iowa. You can measure antibodies, or you can measure the protein, or you can try and grow this in a culture. And if you do want to grow this in the culture, it's nice to let the lab know ahead of time that you're looking for it, because they'll put a special marker on that so they don't accidentally breathe it in. What we treat them with depends on how bad it is, but because he had disseminated disease, he really needed amphotericin, which is a hard drug to take. In his case, he took it for 14 days. He did get a Fanconi syndrome and just started dumping all of his electrolytes. And in the end, he recovered. It took about 6 months for him to get better, and he just finished 1 year of treatment this week. And so he's almost there. It's about 1 year of treatment. Itraconazole is a safe drug. This is what people get treated with for so long, but we do watch for abnormal LFTs, heart failure, and then it needs stomach acid to get absorbed. So if you're going to start a patient on a PPI who is also on ITRA, be aware that you might prevent it from being effective. So we watch those levels. And TNF-alpha inhibitors are great drugs. They work, but be aware that in Iowa they can affect histo. So these are 2 short cases. This is a 40-year-old guy that came in with weight loss, some dizziness, some thirst, and hair loss, and some mild diarrhea. He's got some chronic low back pain and a family history of lupus, but not a lot else. So we want to know our oats. So he works as a painter. He doesn't travel, no animal exposure. He's engaged to his girlfriend of 3 years, and they have a 1-year-old. Then they're healthy. He has a distant history of IV drug use, and that's in remission. So his initial exam is pretty normal. He's thin, but his labs were all funky. So his white count was low, his platelets were low, other things were normal. So he goes to hematology because we're now worried a little bit about this neutropenia, and he has all these studies done. And you'll notice down at the bottom is this positive HIV ELISA test. So in terms of that positive test, do you want to call him and let him know that he's HIV positive? Do you want to order a PCR? And if it's positive, then bring him in to talk about it. Do you want to get a Western blot to confirm it and then talk with him at that time? Or do you want to just wait until the Iowa Department of Public Health calls him? Because they will call him. And if you haven't talked to him, they will. So let's see your answers, and then we'll move forward. Good. So we got to 50, so we'll keep going. So we're going to order a confirmatory, it looks like PCR. And, I brought this case up, and this question in particular up on purpose. When I've gone to HIV support groups, and we talk about when people get their diagnosis, everybody remembers the moment they were diagnosed. And they remember everything about it. And they remember how people treated them, and they remember how they felt. And we actually had a patient just last month get diagnosed, and he was called over the phone, and he immediately attempted suicide. So be aware that just because you know this is a treatable illness, they may not know that. And be sensitive about it. So in his case, the Western blot was sent that was positive, and his HIV PCR was over 1,000, and his CD4 count was 175, which is low. So he has AIDS. So HIV, I'm not going to call this a fantastic illness. There's nothing fantastic about it. This affects people's immune systems, and over time their immune system gets weak, and then they start getting other infections, and they get very sick. So here in Iowa, we had 136 new cases this year, and there are almost 3,000 people that have chronic HIV here in Iowa. Nationally, we had almost 40,000 new cases this year, or I guess 2015, and 1.1 million people that live with this all the time. I wanted to show you the last couple of years we've actually had increases in our rates, which we're worried about in terms of why this is going up. The good thing is that people are testing more frequently, so people coming in with AIDS as their initial diagnosis are going down as a total percentage. So keep testing, keep looking for this. It's not gone. This is acquired through blood and sexual body fluids, so not spit, tears, or sweat. So kissing and hugging and living with somebody with HIV does not give you HIV. And this is the classic HIV curve where a person's CD4 count is initially normal, they get infected, it dips, and then over the next usually about 10 years, it goes down and down and down until about right here when they start to feel sick, and then shortly after they start to feel sick, they start to get weird infections. This is a little different for everybody. It can happen in a year, it can happen in 20 years, but the average is about 10 years. So he probably got his HIV about 10 years ago. And these are some of the infections people can get when they get HIV. One thing not to miss is that HIV looks an awful lot like mono when you first get it. So about 50% of people get it, this syndrome of acute HIV. And if you don't test for it, you won't find it. So know your oats, know if they're at risk for HIV, if they're coming in with the mono syndrome, and just do the test. And people feel weird when you do an HIV test on them, and I just tell people, we do this on everybody. It's just part of it. And remember that they're waiting desperately for the result. So if you get the result on Friday afternoon, call them on a Friday afternoon. Don't make them wait. And most people are asymptomatic for a while. I wanted to show you this curve, if I can. Well, so this is the survival curve for HIV. Back in the early 80s, people lived about 10 days when they got diagnosed. Then we got in the mid-80s and people started to live a few months after they got diagnosed. Then we started getting these different treatments, and you can see that the survival curve has increased till here we are, 2016, and it is estimated now that people with HIV live a normal life expectancy if they can take their medication every day. And the majority of patients take 1 pill per day. That's it. So We know that, but they don't necessarily know that. So you need to be really sensitive as you're talking about it. So he started treatment. He had AIDS. We did some preventative things. His girlfriend was negative. Baby was negative. And we tried to give her some preventative stuff. She just couldn't take it. She couldn't remember. But turns out, after we treated him for just a couple months, his HIV became undetectable, which is important because just this year, finally, the CDC and World Health Organization have concluded, we've known this for a long time, but now it's official, that if somebody's undetectable, they cannot transmit this virus. Which, if you think about a person having HIV and what that implies to them about their relationships and their life, this is huge. This helps us encourage adherence to medicine, and for our patient and his family, it's a big deal, because as long as he takes his meds and is undetectable, he can't make someone else sick. Last case, really quick. 62-year-old bone marrow transplant patient, GVHD, has chronic lung inflammation from her GVHD, or his GVHD, also has some heart failure, gets chronic coughing intermittently, gets some shortness of breath, comes into ED with some phlegm, doesn't have fever, steroids were recently tapered. Here's the labs. They look pretty normal. Procalcitone is normal, a little bit of pulmonary edema, and a sputum culture gets obtained. So this is his sputum culture. And this was here at Mary Greeley. So you can see resistant, 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 resistant. This is a pan-resistant gram-negative rod. I sent out for colistin testing and is resistant to colistin. So what do you want to do with this? We can give some dual therapy of a couple things it was resistant to, but maybe it'll work. We can give one of these newfangled combination antibiotics, see if that'll work. We could try colistin, because maybe the in vitro testing for colistin doesn't really matter anyway. Nobody knows what that means. Let's just try it. Or let's leave it alone and treat his heart failure. So, good. So, I like these answers. So we elected to leave it alone, and he got better with treatment of his heart failure. He did go to a kind of a fancy tertiary facility a few weeks later, and they decided they wanted to treat it, and so they did give him the ceftazidime avibactam, which is like the newest drug on the block for gram-negative rods, and he got really sick with that, and we tested his sputum 3 weeks later, and bacteria is still there. So this is Fantastic Beast number 8. These are highly resistant gram-negative rods. It can be pretty much any type of gram-negative rod, and how they're resistant kind of varies, but what we worry about are these transmissible plasmids that can move from one bacteria to the other. And we don't see very many of these. I think we've had just a couple in the last 2 years. And if they turn up in a culture, you'll be called, and the patient needs to be in isolation. We'll usually be called first. We've probably already heard about it. People that get this usually have been in the hospital quite a bit. They've spent time in long-term care facilities. There might be some association with travel to an area with poorly controlled antibiotics. And usually these are in the urine, if anywhere, because people that have chronic Foleys get a lot of antibiotics and select for really resistant bacteria. Treatment is really challenging, especially if it gets into a deeper site. The ceftazidime avibactam is probably the most studied. But there's these other kind of newer drugs, and you can just try adding colistin to that. This is an important case because this is one of the reasons we have an antibiotic stewardship program. Our goal is to try and prevent this from happening, and this happens when patients get antibiotic after antibiotic trying to get rid of something that may or may not be causing disease. So remember that. Remember the stewardship program is here as a resource for you to help prevent this. Remember that you do not want to bring this home, so you should wash your hands after you see your patients. Antibiotics save lives, and let's keep it that way. So these are our 8 cases. I would have loved to do more, but I'm sorry I went over time anyway. So thank you for all your help with all of these patients. Really appreciate your time, and be happy to hear any questions or comments. Yeah, Dr. Partridge. No, good question, and none of them are contagious. So we get that question a lot from like a malaria case or something. None of them are contagious because they all have this sort of intermediate kind of tick factor or mosquito factor or something else. Leptospira doesn't need any specific isolation either. So they're not human to human usually. Yeah. Yep. So you can carry those on your hands after seeing a patient. So really important to wash your hands.
Your West Nile patient, are they not? Can they get it again once they've had West Nile?
That's a good question. I don't know the answer to that. The fact that they have a vaccine in development implies that they can't, but I'm not aware of data one way or the other.
Okay.
So hopefully he's protected.
Yeah.
Dr. Arbalou, do you know an answer to that question? Are people that have had West Nile virus protected from future West Nile virus? I don't know that either. Okay. Well, thank you very much for coming. Really appreciate your time.